Hello, everyone. Welcome, everyone. We're going to wait for a few seconds until everyone has a chance to come in, as a lot of people are transitioning from other sessions. For anybody just joining, we are waiting a minute or two to make sure that people have a chance to join, as a lot of them are joining from other sessions. Again, we are just waiting for a minute or two to make sure that people have a chance to join us. Let me start with a few instructions, some guidance that we have for you while people start joining us. First of all, welcome. My name is Fernando Botelho. I'm program specialist for assistive technology at UNICEF HQ in New York. Let me explain that we have available to you not just captioning, but also interpretation in numerous languages. Just use the usual features on Zoom to access those alternative languages. The way we are organized today is we are going to have a video and then some presentations, and then hopefully some time for questions and answers. In case you have some difficulty using the Q&A feature on Zoom to submit your questions, we request that you use the chat to submit questions. And of course, you can submit questions at any time throughout our session. Let me explain that this session is about the need for the higher needs for healthcare services that persons with disabilities have when compared to the overall public, the general population. It's not just services, but also a need for rehabilitation and a need for assistive products. I just want to ask that everybody shut off their microphone if you're not speaking, so that we don't have interruptions to our various speakers. So we're going to be addressing, talking about this issue of the need for that persons with disabilities have for healthcare services, but also rehabilitation specifically, and assistive products. They face, in general, higher costs and greater barriers, and they have a much higher likelihood or risk of facing catastrophic health care expenditures. There are different country efforts to cover these costs, and we are going to talk about those, and not just covering the cost of the healthcare services, but also assistive products. And these, of course, across the life cycle of individuals with disabilities. I'm going to start first by sharing with you the bios on the screen, the bios for our various presenters. We have quite a panel today. The video you're going to meet on the video that we're going to present, Glenn David and Merla Rose Reyes. They are from the Benefits Development and Research Department of the Philippine Health Insurance Corporation. After that video, we are going to look at the key asks from organizations of persons with disabilities, and that's going to be brought to us by Omar Siddo, President, National DPO Federation of Niger. And after him, we're going to look at the development of assistive product priority lists. And this is going to be presented to us by Satish Mishra. He's Technical Officer, Disability Rehabilitation, Palliative and Long-Term Care from the WHO Regional Office for Europe. After Satish, we are going to have a presentation about global evidence on social protection and access to healthcare for persons with disabilities, presented by Morgan Banks, Assistant Professor, Disability and Global Health at the International Center for Evidence on Disability, which is part of the London School of Hygiene and Tropical Medicine. So let's go ahead and start with the video. Thank you.
We would like to thank UNICEF and the organizers of this event for inviting the Philippines to take part in the side event of the Disability Conference. I am Merla Rose Reyes.
And I am Glenn David from the Philippine Health Insurance Corporation.
And we are here to share with you our journey towards universal health coverage of persons with disabilities in the Philippines. Over 1 billion people, of approximately 15% of the world's population, is said to have some form of disability. About 80% of them live in low-income countries. In the Philippines, 1.57% of the population have a disability, and for every 5 persons with disability, one was 0 to 14 years of age. Out of 1.5 million children who need assistive devices, only 5% have access to assistive technology. And based on a study, children with disabilities have to travel an average of 5 to 6 kilometers to reach the nearest health facility. The Philippines was one of the first countries to nationally ratify the Convention of the Rights of Persons with Disabilities by enacting its own Magna Carta for disabled persons through Republic Act No. 7277, which provides for the rehabilitation and self-reliance of disabled persons and their integration into the mainstream of society and other purposes, otherwise known as the Magna Carta for Disabled Persons. Through this law, the persons with disabilities are ensured that essential health services are made available to them at an affordable cost. In line with the Magna Carta, the Department of Health came up with a National Health Program for Disabled Persons, issuing an administrative order outlining a new framework to strengthen the implementation of the program for the health and wellness of persons with disabilities. Meanwhile, by virtue of Republic Act No. 7875, also known as the National Health Insurance Program of the Philippines, Administered by the Philippine Health Insurance Corporation, or PhilHealth, the country shall prioritize the healthcare needs of the underprivileged, sick, elderly, persons with disabilities, women, and children. These two laws preceded the implementation of the Universal Healthcare Act, or Republic Act number 11223. Through the UHC Act, every Filipino citizen is automatically enrolled to the National Health Insurance Program and gives access to the full continuum of health services they need, from screening, prevention, curative, rehabilitative, and palliative care, while protecting them from financial hardship. Corollary to the UHC Act, the Philippine government amended the Magna Carta for persons with disabilities to effect the mandatory coverage of persons with disabilities under the National Health Insurance Program. The premium contributions for all persons with disabilities are paid by the national government, while those who are formally employed have their premium contributions shared equally by their respective employer and the national government. Further, through the revised Magna Carta, PhilHealth is tasked to develop exclusive benefit packages for persons with disabilities that will address their healthcare needs. PhilHealth recognized the potential towards functional independence and productivity of persons with physical disabilities, particularly those with limb loss deficiency, once they are provided with quality and appropriate prostheses. In year 2013, PhilHealth worked with the experts on rehabilitation medicine and relevant stakeholders and launched the very first exclusive benefit package for persons with disabilities that we call the Z benefits for mobility, orthosis, rehabilitation, prosthesis help, or Z-Morph. This will be further discussed in the next slides. In 2017, under the technical assistance of UNICEF, the Department of Health, PhilHealth, Department of Social Welfare, and other relevant government agencies and organizations collaborated to design an integrated approach of improving access to assistive technology and rehabilitation services for children with disabilities.
On June 21, 2012, PhilHealth launched the Z benefit packages, which provides relevant financial risk protection against conditions that are considered medically and economically catastrophic, especially for the marginalized sectors of society. For persons with disabilities, PhilHealth implemented Z benefits for mobility, orthosis, rehabilitation, prosthesis health, or ZMORPH in 2013 to include provisions of assistive device which covers lower limb prosthesis for 18 years old and above. The services included in this benefit package are pre-prosthetic assessment, prosthetic measurement, fabrication and checkout, discharge assessment, and rehabilitation program when warranted. 3 years after the development of ZMORPH, the corporation expanded the program to cover upper and lower limb prosthesis, lower limb orthosis, and spinal orthosis with at least 6 physical therapy or occupational therapy sessions. Through the collaborative efforts of the Department of Health, PhilHealth, National Council on Disability Affairs, non-government agencies, experts, and healthcare providers, and with the technical assistance from the United Nations Children's Fund or UNICEF, PhilHealth developed the benefit packages for children with disabilities for 0 to less than 18 years old, covering developmental disability, mobility impairment, visual disability, and hearing impairment. These include services for assessment, provision of assistive devices and seating devices, rehabilitation therapy, and discharge assessment. It also includes replacement of the devices and yearly services for seating devices.
PhilHealth contracted qualified and willing healthcare institutions to provide the services for the benefit packages for children with disabilities. The UNICEF and Physicians for Peace identified access hubs that were capacitated to provide the complete services needed for children with disabilities. One of which is the University of the Philippines, Philippine General Hospital, where we are at right now. Other contracted healthcare institutions are the University of the East Ramon Magsaysay Memorial Medical Center in Quezon City, Eastern Visayas Regional and Medical Center in Tacloban, Leyte, and Southern Philippines Medical Center in Davao City. PhilHealth capacitated its technical staff in 2019, familiarizing themselves with assistive devices from various facilities such as the Resources for the Blind Incorporated, University of the East Ramon Magsaysay Memorial Medical Center, and the University of Santo Tomas. PhilHealth continues to engage relevant stakeholders, including persons with disabilities and their families, to achieve whole of government and whole of society approach to achieve universal health care and ensure that no one is left behind.
Thank you very much to Glenn David and Merla Rose Reyes. The example of the Philippines is rather fascinating and perhaps a model to be followed by so many other countries in this track that we are in, that we hope to be in. Now we are going to be joined by Mr. Siddo, joining us from Nigeria to present some of the asks, the key asks from organizations of persons with disabilities. Please, Mr. Siddo.
Bonsoir à tous. J'espère que vous pouvez m'entendre depuis Niger. Je suis Siddo Nouhou Oumarou et je suis président de la Fédération nigérienne des personnes handicapées. Je voudrais parler de la couverture de santé et des périphériques d'assistance. Je ne suis pas sûr qu'on m'entend bien, mais je continue quand même. Je voudrais dire que le droit... Alors, le droit d'accès aux périphériques d'assistance et la couverture de santé ne peuvent pas être dissociés. C'est un droit qui doit être reconnu au plus fort parce que les personnes handicapées, bien qu'elles partagent les mêmes besoins en termes d'accès aux soins de santé, elles ont des besoins particuliers qui peuvent être satisfaits seulement que si elles accèdent équitablement aux périphériques, aux aides techniques et notamment les aides d'assistance qui sont inclus dans la couverture de santé universelle. Le problème de leur accès aux aides techniques, c'est la capacité de financer ces aides techniques qui, on le sait, coûtent excessivement cher et la capacité économique des personnes handicapées est généralement très réduite en fonction de la pauvreté de la plupart d'entre elles, en particulier dans les pays du Sud. Et pourtant, leur incapacité d'accéder à ces périphériques d'assistance affecte gravement leur participation à la vie de leur communauté et à leur survie parfois même. Il faut relever que la plupart des régimes de santé ne prennent pas en compte cette couverture et cet accès aux périphériques d'assistance aux aides techniques. et les régimes de santé sont en général contributifs. Ça veut dire qu'il faut que vous payiez pour que vous puissiez avoir accès à ces régimes. Et on sait que les personnes handicapées, généralement, travaillent dans des secteurs informels ou dans des secteurs formels, mais avec beaucoup moins de revenus qui leur permettent de souscrire à ces revenus-là. En plus, même ceux qui ont un emploi formel et qui ont un revenu ont parfois des difficultés d'accéder à cette couverture.
We're having some difficulty with your audio right now. Perhaps you can turn off video to improve the connection, the quality of the connection. It looks like Mr. Siddo has had a disconnection. So we're going to go ahead and continue with our presentations. I apologize for the technical difficulties. And if you have comments or questions to Mr. Siddo, please feel free to share them in the Q&A. And we are going to try to... Oh, you're back. Please continue. Yes, we are not able to hear you right now. Well, it looks like the technical difficulties remain. We are going to go ahead in the interest of time and continue with our other panelists. We will have a chance to send questions to Mr. Siddo through the Q&A. If we have a chance to have questions at the end, we'll give him a chance to talk to us again. So as we described earlier, we have with us an expert, Mr. Satish Mishra. He's going to talk to us about assistive product priority lists. This is a very interesting way of approaching the challenge of providing assistive products. And please go ahead, Mr. Satish. Thank you.
Thank you, Fernando. Thank you very much. My name is Satish. I'm, as Fernando mentioned, and I'm joining from the regional office of World Health Organization. I will be speaking today about how coverage and cost of assistive products can be covered through development of national priority assistive product list, and how that development process can help to ensure that the coverage as well as the financing for those assistive products are available. Can I have the next slide, please? In 2016, WHO came with a priority assistive product list, which includes a list of 50 assistive products, which are considered to be essential for well-being and everyone in need should have access to those essential priority assistive products. This list was based on an example which was done similarly in the field of medicine, where in late 70s, essential medicine list was developed. And through that, countries had more access to medicines, had that essential medicine list, had created more awareness, had created more competition, and mobilized more resources. So when we were working on the priority assistive product list, which was launched in 2016, we looked at the medicine sector and we saw that the essential medicine list has been quite successful. And how can we learn from that and use it in the field of assistive technology? And that was the whole rationale on why we developed the list in 2016. Can we have the next slide, please? I'll give few examples of the work which is happening with regards to assistive product development in the countries. In the European region, I'll take example from Tajikistan, where a list was developed in 2018, and in Georgia, where a list was developed in 2021. And in both the countries, the process of national priority assistive product list development followed a very similar process. Priority assistive product list has been also developed in other countries, but I want to bring example from these two countries. The whole process of development of a priority assistive product list involved understanding who are the stakeholders, who are the users, who are the providers, what are the different government ministries involved in that process. In addition to that, we also look at what is the demand of different assistive products. What kind of assistive products in the field of mobility, in the field of vision, in the field of cognitive development, in field of communication and others, another functional domain are needed by population. And this we do through a tool which is called Rapid Assistive Technology Assessment. In addition to that, we also look at the system side of the thing, which is done through a WHO tool on assistive technology assessment of the capacity of the system's capacity to provide assistive products. And in that, we look at what are the human resources available, what are the policies available, what are the financing available, who are the key stakeholders involved in this process. And based on those data, we then identify, based on those data coming from the demand side, from the population side, from the data coming from the system side, the supply side, that helps us to develop the list which is needed at the country level. The next slide, please. And before the list is finalized, we present the data which is coming from the population survey on the need of assistive products. We present the data on the system's readiness to provide assistive products. Based on that evidence, we gather different stakeholders, and through a consensus building process, we try to develop a national list in the country. In this whole process, the global WHO priority assistive product list act as a reference for us, and that reference helps us to understand what are the boundaries and how far can we extend those boundaries and have more assistive products in the countries, or which assistive products needs to be dropped and needs to be added in. So the global list act helped us to be as a reference document in this whole process. The next slide, please. In Georgia, prior to the development of National Assistive Product List, there were 14 state-funded assistive products. In Tajikistan, prior to development of the National Assistive Product List, there were 11 assistive products on their list. And most of those products were focused on mobility. Both the countries, Georgia and Ukraine, who developed the priority assistive product list, have extended, following the whole process, have extended the list to 30 products, more than doubling the range of government-funded products, and especially a significant increase of products on priority assistive product list, priority assistive products required in the area of vision, in the area of communication, in the area of self-care. After the adoption of the list in both the countries, both countries has significantly increased the assistive technology budget to accommodate the new needs which came out from the national list. In addition to the development of list, what is also very important is to develop standards and specification for each of those products which are listed in the national list. Next slide, please. In many countries, assistive technology resources are low. There is challenges on assistive technology budget. There are challenges with regards to workforce. There's challenges with regards to capacity of the government to regulate the market. in terms of procurement of the assistive products, in terms of quality control, and the list can go on in terms of challenges. The whole process of development of a national assistive product list helps us to focus on interventions where the needs are highest, where majority, where we need to focus more in the countries. And that's the beauty of this, of the development process of the list in the countries. Assistive product list in the country can help us to mobilize resources for assistive products, for different assistive products required, advocate to government agencies and funding agencies where basic needs are not met, and how the funding of assistive technology can match the list which are developed in the countries. The other advantage of increasing access and coverage and funding for assistive product through the development of an assistive product list in the country is that it contributes in a systematic, coordinated approach towards increasing access to assistive technology. Assistive technology sector is typically fragmented. There are different development agencies with different focus. There are different ministries involved in assistive technology with different priorities, and resources are scattered. And a lot of waste through the funding of ad hoc initiatives that are not always sustainable and do not fit into a broader strategy. These fragmentation leads to duplication of services and waste of resources. And this is what this national priority assistive product help us to avoid. I want to also emphasize that no model fits all the countries in terms of funding of assistive products. We always have a combination of public or private or public-private, or the funding coming from different streams, whether health, social protection, whether education, labor, or other sectors are involved. I want to end the presentation with 5 key takeaway messages. Number 1, to further prioritize assistive technology within the country, it is important that it is done in line with the health and the demographic trends of those countries. Assistive technology needs in the population are increasing, but unfortunately, a lot of those are going unmet. Number 2, we need to integrate assistive technology into health system, into education system, into social protection system, but more, and in that whole process, we need to equip the leaders of those systems on the knowledge and resources which are required on assistive product access in the countries. This needs to be reflected further in the planning, in the information, workforce, and service delivery planning and development process. Number 3, integrating assistive technology into health financing, for example, or in health benefit packages are extremely crucial if we want to go from the health sector perspective, as this is how we mobilize and pool the funds needed for greater population coverage, and integration is essential over there. Number 4, strategic purchasing is a key approach, which is what this national priority assistive product list essentially contributes to. And through this process, it helps us to support greater efficiency and quality of assistive products. Number 5, which is the last one sector cannot do it all. It is important to work across different sectors to coordinate coverage and share the evidence and the data. Setting common goals for access of assistive product in the country through the process of development of national assistive product list, and keeping the goals of equity and quality of care is an important goal to keep in mind while embarking on this journey. The next slide, please. Thank you. Thank you, Fernando. And back
Wonderful.
to you.
Thank you very much, Satish. This is really interesting. It matches perfectly with what we have observed at UNICEF, that we need a cross-sectoral approach to make sure that assistive products are available, that we need a systemic strategy to make sure that things are scaled up and sustained over time. Thank you so much, Satish. So we'll move on to Professor Banks, Morgan Banks, who will talk to us about evidence on social protection. Please, Professor Banks. Thank you.
Hi, everyone, and thank you, Fernando, for that introduction. So today I'm going to be talking about the role of social protection in improving access to healthcare for people with disabilities, and particularly in ensuring financial protection in that access. Next slide, please. So we know that people with disabilities often have high health costs. So it's often said that people with disabilities have higher health needs compared to people without disabilities, as they require both the same general health services as the general population, but they also require disability-related health services, such as rehabilitation or assisted devices. Back in 2011, the World Report on Disability found that people with disabilities were 50% more likely to experience catastrophic health expenses. Now, these are only the health expenses that people are able to afford. We also note that people with disabilities frequently have unmet health needs, and cost is a major barrier to meeting those needs. So, for example, in Sri Lanka, people with disabilities were 3 times more likely to report that they had an unmet health need because they couldn't afford the services they required. Similarly, in 8 sub-Saharan African countries, 62% of people with disabilities needed but couldn't afford rehabilitation services. Next slide, please. More and more countries are implementing cash transfers, particularly disability-targeted cash transfers. And the rationale given for these programs is that they can help to cover the extra costs of disability, of which healthcare costs are often a big source. And we do find that when people with disabilities receive cash transfers, healthcare is often a major source of spending. So here we have data from Nepal, Vietnam, and the Maldives, which shows that 43% of people in Nepal, 27% of people in Vietnam, and 45% of people in the Maldives reported that healthcare was their main use of the disability allowance. Next slide, please. And we've also found from different studies that cash transfers can have some modest impacts on health for people with disabilities. So, for example, in Lesotho, cash transfer receipt was associated with improved self-rated health and likelihood of seeking healthcare. In the Maldives, cash transfer receipt led to some improvements in overall health rating. And in Vietnam and Nepal, 40 and 64%, respectively, reported that the disability allowance was at least somewhat helpful in helping them to access healthcare. So we do see some modest benefits of cash transfers in improving access to health. Next slide, please. However, on their own, cash transfers may be insufficient to cover all healthcare costs for everyone. So one of the major issues is that the value is not adequate for many people. So for example, in Nepal, 23% of disability allowance recipients were still having catastrophic health costs even after receipt. And one of the reasons why cash transfers may not be, at least alone, the best policy instrument for covering health costs is that health costs are highly variable between individuals. So they can vary by impairment type and severity, by where a person is, such as how far they have to go to health services and what health services are available. And there's also some evidence that healthcare costs can vary by gender. Next slide, please. As an illustration, I have here a graph of out-of-pocket healthcare costs for Alzheimer's in Thailand. So this is a single impairment type, and the costs have been broken down by severity. So we see on average, for example, the cost for mild Alzheimer's is about $500 per year, which can go up to about $1,000 per year for severe Alzheimer's. However, even within the same grouping of severity, there is a wide range of costs. So for example, if we look at a moderate severity, we could see that costs range from about $520 all the way up to $1,600. So from a policy perspective, setting a cash transfer value that would cover all of these costs adequately would be very challenging. You would need very many different levels. And this is just one type of impairment. And typically disability allowances only have one value or maybe a couple values. So you could see the challenges policy-wise of adequately covering every person with disabilities' healthcare costs through cash transfers alone. And as a result, the value of cash transfers is often set to a value that is not enough to cover most people's healthcare costs. So for reference, in Thailand, the value of the disability allowance is about $275 per year. So we would see with this that that value would only cover the healthcare costs for people at the lowest range of costs for mild Alzheimer's. So for everyone else, they would still have very high out-of-pocket spending. Next slide, please. Consequently, there's a need to look at other policy instruments within social protection to complement cash transfers, in particularly social health protection. So social health protection can involve social health insurance or national tax financed health systems. And these can be used together with cash transfers as well as other programs. So Satish brought up the importance of multi-sectoral responses, and this is true here as well. But social health protection is definitely needed in order to address disability-related extra healthcare costs. It carries many benefits, so it can be used to address the high variability, so people can access the services they need when they need them. It's also more helpful against protecting for very high one-off costs. So someone might need to save many rounds of a disability allowance in order to be able to meet a cost of, for example, an accident or a surgery. They're also less open to misuse and resentment. So we saw how high some healthcare costs could be, and it might not be politically feasible to give a cash transfer of that amount, as it might create tensions in communities. However, providing someone, for example, a wheelchair or hearing aid would not necessarily produce that same level of resentment. Next slide, please. As more countries are starting to implement social health protection, there are some key considerations for ensuring those systems are disability inclusive. So very importantly is the scope of coverage. So some programs have either no or very limited coverage of disability health services and of assistive devices that are amongst the package of covered services. So there is a need to ensure that these services are covered so that programs are relevant to people with disabilities. It's also important to consider the level of financial protection that are offered. So many programs involve some level of individual contribution, either through monthly or annual contributions or through co-payments at the point of use. So while these are better than paying entirely out of pocket, they can still be prohibitive for some people with disabilities who might need to use healthcare frequently. There are some policy solutions. So for example, in Vietnam, there are subsidies for people with disabilities on the co-payments and contributions. It's also important for countries to consider the eligibility criteria. So social health insurance has typically been tied to formal sector employment, but we know people with disabilities are much more likely to be working in the informal sector. So providing options for people who are not working or in the informal sector are important. Private health plans may also have discriminatory conditions, such as denial of coverage for people with pre-existing conditions, such as a disability. And then finally, social health protection needs to be considered within the context of broader health system strengthening. So ensuring that there is a good availability, quality, and accessibility of services that people with disabilities require, in particular, rehabilitation and assistive devices. Next slide, please. So social health protection is a very encouraging policy instrument for addressing disability-related costs. It is also an area that requires further research in order to inform those policy responses. So we need more research looking at access of people with disabilities to different social health protection programs that are currently available in countries. We also need studies looking at the adequacy of these programs. So how well do they cover disability-related health services, and what type of financial protection do they offer? And then finally, we also need impact evaluations of social health protection on health outcomes and financial protection amongst people with disabilities. There is some promising evidence here. So for example, in Turkey, the implementation of a universal health insurance program was associated with a 34% decrease in total, so not just health-related, but total disability-related extra costs. So in summary, I think social protection, health protection is a promising tool within the social protection toolkit, and one that we hopefully see implemented more over the coming years with considerations for how to make it disability inclusive. Thank you, and back to you, Fernando.
Thank you so much, Morgan. This was fascinating. It seems that one of the greatest challenges of our sector is the tremendous diversity of needs and potential solutions, which is typically more challenging for law and legislation and other, public policies, which tend to be have some difficult time customizing their approach. But your research is a great contribution to mapping out, what can we do to address this, and what has been done and has worked, and what remains to be researched and learned. So we have a few minutes only for maybe one question. If we don't have a question, I have one myself. Please feel free to interrupt me, but I think we have not received any questions. So I'd like to ask to Merla, Reyes, and also Glenn, David, about the list the approach that has been taken in the Philippines. So one thing that comes to mind is there a timeline? Do the products that are covered by the Philippines service, is this list renewed every 3, 4, 5 years? Is there a process to add new products, or even just adjust the specifications for existing products as technology changes? Please go ahead.
Thank you for that question, Fernando. Good morning, good afternoon, and good evening to our attendees of the side event. The list of the assistive devices that are covered by the National Health Insurance Program is reviewed and maybe expanded to other assistive devices based on the inputs from our stakeholders, from patients, and from the experts. And when availing the assistive devices, we set a limit. For example, the prosthesis for 18 years old and above may be availed of by the patient every 5 years, and for a maximum of 2 times in his or her lifetime. So that's how the benefit package for assistive devices work.
Well, that's very interesting. And let me also ask, is there a provision for either through this program or another program for services for persons with disabilities? Because this is very much a health-focused program from what I can tell, but sometimes you need interpretation and other services that are not so much connected to health, but maybe to employment or social protection in general, or education even. Do you know of an approach such as that in the Philippines?
Yes, thank you for that question. Again, we are, as mentioned in our presentation, the Department of Health organized a technical working group composed of representatives from different government agencies, and each government agency is expected to perform their respective mandates with respect to the provision of services for persons with disabilities. For example, the Department of Education is focused on establishing programs for children with disabilities. And then the Department of Social Welfare and Development has also another set of different programs and activities for persons with disabilities. And these include conduct of surveys or studies and livelihood programs for them. And of course, for the Department of Health and for the Philippine Health Insurance Program, we provide services in relation to health and assistive devices.
That's wonderful. Thank you so much, Merla. It's been a pleasure to meet you and every one of our panelists. We've unfortunately run out of time. I'd like to encourage all of you to join us in the networking section of the site and also check out the agenda so you know what other sessions are being presented today and tomorrow. Thank you so much to everyone. Have a nice event and we'll see you soon. Bye-bye.